So family medicine is a specialty that is focused mostly on being able to meet the needs where the needs are greatest. So we know that more than 75% of Kenyans live out from the major cities, and yet probably only 20–30% at the maximum physicians are working in those areas. That huge mismatch means that the greater majority of Kenyans are not getting the quality care that they deserve from not having enough personnel. We want to address that by training the physician who will go there and be a part of that. But that takes a special person. But most Kenyans have a background of their home up country. They have their grandma, their grandfather that live there. And grandma and grandpa want to have good care too. And most medical students, when they start school, they will tell you that that was something that was in their mind when they wanted to go to medical school. But yet, through the socialization that occurs in our medical education system, almost all of that altruistic desire gets socialized out of our medical candidates. They start seeing all the specialties. They see the lure of the big city, perhaps more of an income that could be in a bigger city. And so that earlier altruistic sometimes wanes away. We want to keep that alive. We think Kenyans want to serve their country, and they just want to know how to do it. And so a specialty, family medicine, is able to help them gain the training that will give them what they can so they can join with 2 or 3 of their colleagues and be the core of the specialists that will be in any one of these county hospitals, usually from 70 to 150 beds. Right. So family medicine is a specialty that, in a sense, is a specialty of generalism, because we need these doctors to have skills in all the major areas of medicine. If they're going to be out in a county hospital without other specialty backup, they need to know how to do emergency surgeries. They will learn how to do, of course, emergency obstetrics and C-sections. They will be available to do pediatric and internal medicine care. They'll know HIV care well. They'll be able to help the team with that. Orthopedic and trauma care. They'll also be versed in systems care so that the health centers and dispensaries that are under their watch are able to be managed well, and will be a part of the educational team to be sure those cadres also get continuing education, a dream that the ministry has had for a long time. They can take call with each other. They don't have to be on call for just one specialty and be there all the time. So it has a logical consistency to how it can work together. It's a Master of Medicine program. Lasts 4 years. It's usually done in larger hospitals to start, and then often will be finishing in smaller sites so that a person can do care across all different specialty care areas. The training is first available at Moi University starting 2005. We now have 30 graduates from that program serving all across the underserved and rural parts of Kenya. None has gone back to work in the city and hang a shingle and make private practice. There's been a lot of dedication to do the job they were trained to do. Now we have additional programs. Aga Khan started approximately 3 years ago and will graduate a class in a year. Maseno started a cohort last year. And this year, 2015, we are also beginning programs in Kabarak University, where I'm the head of department, and also with my colleague, Dr. Thigiti, at Kenyatta University. This person can be a physician to help oversee that. No one doctor can do that alone. And that's why we've suggested to the ministry, and they've been cooperative, to see that at least 2 of these doctors have to be posted if there's going to be any posted to a county or a smaller hospital. Otherwise, within a year or 2, they'll burn out too, and they can't afford to do that. These are valuable doctors that want to help, but they need to be able to do it in a very healthy, family-friendly way.